Good evening, one and all. I welcome you all to today's Navigate CME program. I would like to request Professor Umesh Kapil sir, the Secretary of National Academy of Medical Sciences, to provide the welcome address.
Namaskar and good evening to all. On behalf of National Academy of Medical Sciences, I welcome all the participants. Our most respected coordinator, Professor Rakesh Chadda sir, who is the chief coordinator of a series of lectures which we are organizing, which NAMS is organizing in the field of psychiatry. We have Dr. Preeti Arun today as a main speaker, and ma'am is a professional head Department of Psychiatry, GMC at Chandigarh, and she's also additional director, Mental Health Institute, Government Rehabilitation Institute for Intellectual Disabilities at Chandigarh. Madam is a renowned psychiatrist, and she has a large number of publications. And I must say one thing, my personal experience, autism is I don't know, what should I say, but it changes the life of an entire family. And what I have observed that autistic childs are very good. They have their own expertise, own areas. The problem comes when we want them to function or develop them according to our instinct. And this is something very informative lecture which we are going to have, autism spectrum of disorders. And once again, I request my most humble thanks to Dr. Professor Rakesh Chadda and Preeti Arun for helping us, National Academy of Medical Sciences, in organizing this series of lectures. I'm sure that these lectures would be enjoyed by all the participants. We are going to put all these lectures and the PowerPoint slides on the NAMS e-library, which will be on the NAMS website. And all the participants, there were 200 of participants which have joined on the YouTube. On the NAMS website and get educated. With these few remarks, I hand over to Preeti for further proceedings. Thank you very much.
Thank you, sir. I would now like to invite Professor Rakesh Kumar Chadda, sir, who is the professor and head in the Department of Psychiatry, and he is the chief of the National Drug Dependence Treatment Center at the All India Institute of Medical Sciences, New Delhi. He is also the president-elect of World Association of Social Psychiatry. He is a fellow in the Royal College of Psychiatrists of UK. He is an international distinguished fellow of American Psychiatric Association, honorary fellow World Association for Social Psychiatry. He is a fellow in the National Academy of Medical Sciences, associate editor of the British Journal of Psychiatry, and handling editor of British Journal of Psychiatry International. And he's a recipient of 14 national awards in psychiatry. I would now like to invite Professor Rakesh Chadda, sir, to provide his remarks for today's CME. Over to you, sir.
Thank you, Dr. Preeti. And good evening, friends. First of all, I would like to thank Dr. Shiv Sareen, President, National Academy of Medical Sciences, and Dr. Umesh Kapil for this excellent initiative. And Department of Psychiatry, the specialty of psychiatry has been given this opportunity to have a series of lectures. So psychiatry has got a status in the National Academy of Medical Sciences, I would like to say. And today we are having second in the series of lectures. Today's lecture is being taken by Dr. Preeti Arun, who has who is a professor and head at Government Medical College, Chandigarh, and child psychiatry has been her area of interest, and she is the one of the few psychiatrists in the country who have devoted a lot in the field of child psychiatry, and he is, I think, she is one of the best persons to talk about autistic spectrum disorders. This is some condition which is most psychiatrists feel have difficulties in attending to the patients who are presenting with symptoms of autism. At least I have never been comfortable in dealing with the children with autistic spectrum disorder, and it's a condition which is now well recognized as one of the disabling conditions, and it's a great trauma for the parents whose child is found to suffer from the illness. So in that background, we thought that when we are talking about like topic from child psychiatry, this would be one of very important topics on which we should have a lecture from Dr. Preeti, and this would clarify a lot of uncertainties which exist in our mind, because he has a wide experience in this area. Dr. Preeti, please.
Thank you, sir. So now I'd like to invite Professor Preeti Arun, ma'am, for today's lecture. Over to you, ma'am.
First of all, I'm really thankful to National Academy of Medical Sciences, President Dr. S.K. Sareen and Secretary Dr. Umesh Kapil, and also Dr. Rakesh Chadda for giving me this opportunity to be here and sharing with you about autism spectrum disorder. Thank you so much. So I will be sharing my screen. So today I'll be talking about autism spectrum disorder, and it is a neurodevelopmental disorder characterized by early onset, persistent impairment in social communication, interaction, and restricted repetitive patterns of behavior. When we look at characteristics of ASD, we are not talking here of symptoms, because it is a condition and it is not a disorder. It's not a disease of which we can talk of symptoms. So it is a very, very nice and bright spectrum on which we have executive function, sensory processing, repetitive behaviors, motor skills, perseverative thinking, social awareness, verbal and non-verbal communication, and information processing. All these put together in different combinations make autism spectrum disorder. This is a leading cause of disability among all mental disorders in less than 5 years age group in autism spectrum disorder in USA. Recent CDC data shows 1 in 36 children of 8 years of age. As of 2018, about 1 in 450 children under the age of 10 have autism spectrum disorder in India. So when we look at this graph, this is about the autism spectrum disorder in USA. And we can see that it is very steeply climbing. 2000 onwards, it is climbing very steep. Now we look at prevalence world over, then in different studies, there are different figures from different countries over different span of time. But somewhere around 1 in 300-400 or so. Maximum is in USA. When we look at Asia, again there is variability with Japan and South Korea having a very high figure. When we look at India, the prevalence studies in community are, I could find 4, which are prevalence studies in community. From Himachal Pradesh, it was 15 per 10,000. There was a school children study from Kolkata, 23 per 10,000. In Kerala and semi-urban community, 23.3 per 10,000. And the study which we conducted in Chandigarh, it gave a prevalence of 22.5 per 10,000. So more or less similar figures from across different regions, all 4 zones of India. This is the bar chart for the studies. We can see that all Kerala, Himachal, Kolkata, Chandigarh have similar and much lesser than other countries of Asia. So when we look at nosological status, in DSM-4, there were different disorders: autistic disorder, Asperger disorder, pervasive developmental disorder, NOS, Rett disorder, childhood disintegrative disorder. Almost similar in ICD-10 with childhood autism and Asperger syndrome, atypical autism, etc. In DSM-5, a spectrum approach was taken, and same is there in ICD-11 also. And in these different, the disorders are not categorized separately, but these are all subsumed under autism spectrum disorder. All kinds of disorders are there. In ICD-11, it can be without disorder of intellectual development and impairment of functional language. These two are to be separately commented upon. When we look at the instruments which are available in India for assessment, the gold standard instruments are like Autism Diagnostic Interview, Autism Diagnostic Observation Schedule, Childhood Autism Rating Scale, and these are used to diagnose and characterize autistic phenotypes, but all these are very expensive. Training is also required, hence these are unaffordable in Indian setup. There are 2 indigenous scales which have been developed and made available free of cost. One is by International Clinical Epidemiology Network Diagnostic Tool for Autism Spectrum Disorder, or INDT-AST. And this was developed when there was DSM-4-TR. Then there is next modified version, which is AIMS Modified Incline AST, and that is as per DSM-5. And another scale, which was Indian Scale for Assessment of Autism. And this was developed primarily for disability assessment. But since this was the only scale at that time when it came, so it was used for all other purposes also, like diagnosis, phenotype, and everything. So the government of India has issued guidelines for using these 2 scales for assessment and disability certification in autism. For screening, Indian Autism Screening Questionnaire, or ISEC, it is same data set as ESA. It is 10 items. It screens from 3 to 18 years. Then Chandigarh Autism Screening Instrument, CASI, it is 37 items. It screens from 1.5 to 10 years of age. And then CASI BREF, which is 4-item scale. Now, when we look at etiological variables, there is multifactorial inheritance, which has environmental factors and genetic interaction and epigenetic factors. Environmental factors are there like toxins, gene mutation, trauma, diets, food, radiation, lead, chemicals in groundwater, etc. In genetic, it can be autosomal dominant recessive, sex-linked dominant recessive. Then coming to psychological theories, there is a lack of central drive for coherence with a consequent focus on dissociated fragments rather than integrated wholes, leading to a fragmentary and overly concrete experience of the world. So this is what is usually seen in autism spectrum disorder. There is also deficits in executive functioning, that is in the capacity for abstracting rules, inhibiting relevant responses, shifting attention and profiting from feedback, and maintaining a focus on multiple aspects of information in decision making. When we look at hereditary, scientists have observed a concordance for autism in about 60 to 90% of monozygotic twins. So certainly there is some genetic. They have also observed a concordance for autism of about 5 to 10% in dizygotic twins. Hereditary or genetic factors are responsible for 90% of autism cases. Similar results from family research show that the percentage of autistic siblings is about 2 to 7% or much higher than the percentage in general population. which is about 0.5%. Recent specific findings regarding neurolegens, SHANK3, contactile associated protein 2, and urexin 1, and a growing understanding of the biology of the Fragile X mental retardation 1 gene have provided the first concrete insight into the molecular and cellular pathology underlying autism. It is clear that no single gene accounts for a majority of affected individuals. Relative contribution of genes is thought to be quite large. Influences other than variation in the DNA sequence are likely to turn out to be important as well, including epigenetic mechanisms and environmental factors. Indeed, one of the most important outcomes of the successful search for autism transcripts will be the light it will shed on non-genetic, potentially modifiable risks. Evidence of multiple genetic subtypes shows support for autism gene on chromosome 7, and there is less compelling evidence for gene on chromosome 3, 4, and 11. When we come to neurochemistry, increase in peripheral levels of serotonin is there, though significance is unclear. Hyperdopaminergic state of brain explains overactivity and stereotype movement seen in autism. And hence, dopamine blockers are effective in reducing the stereotype behavior. Possibly that endogenous opioid causes social withdrawal and unusual sensitivity to environment. And this was the rationale for use of naltrexone in treating children with autism. When we look at new research breakthroughs, the cell danger response hypothesis is reviewed as a new unifying theory for the cause and treatment of autism. Evolutionarily conserved metabolic response that protects cells and hosts from harm. It is triggered by encounters with chemical, physical, or biological threats that exceed the cellular capacity for homeostasis. And the concept of functionally polarized M1 and M2 mitochondria is introduced. Then oxytocin and vasopressin pathways are associated with social behavior in ASD, and so these are also considered to be important. When we look at biomarkers, elevated serotonin almost exclusively in plexus are seen. And because 5-HT is known to be involved in brain development, it is possible that the changes in 5-HT regulation may lead to alterations in neuronal migration and growth in the brain. Several studies found that increased total brain volume in children younger than 4 years of age with ASD, and about 5 years of age, 15 to 20% of children with autism develop macrocephaly. Increased size of amygdala in first few years of life, followed by a decrease in size over time, is also seen. The size of striatum has also been found in several studies to be enlarged in young children with autism spectrum disorder, with a positive correlation of striatal size with frequency of repetitive behaviors. fMRI studies have provided evidence that individuals with autism spectrum disorder have a tendency to scan faces differently. They focus more on the mouth region of the face rather than on the eye region. Rather than scan the entire face multiple times, individuals with ASD focus more on individual features of the face. And in terms of theory of mind, fMRI studies find differences in activation in brain regions. Now, theory of mind, I'll come to it later again. Dysfunction of the mirror neuron system is thought to be activated during imitation or observation of behaviors. So there's also dysfunction seen. Atypical pattern of frontal lobe activation, especially fusiform gyrus, have been found in ASD during face processing tasks. So there are various areas of brain which are of potential importance in autism. So now coming to one controversy, that do vaccines cause autism? There's one Danish study suggesting no link between autism and thimerosal. And this was also eliminated from vaccines in 2001, but there has been no decline in incidence of autism. In fact, there's increase in prevalence. Coming to placenta research, it is something very interesting research which is going on, which says that a placenta with 4 or more trophoblast inclusions conservatively predicts an infant with a 96.7% probability of being at risk for autism. So currently, the best early marker of autism risk is family history. Couples with a child with autism are 9 times more likely to have another child with autism. And there's also research on kinesthetic movements while playing video games for early identification. So now coming to the diagnosis, how do we diagnose? One, we use Ames modified inclinacy. We use diagnostic criteria like DSM-5 or ICD-11. MCHAT is used for screening because this is easily available everywhere. And ESA is also used at many places. So autism spectrum disorder has 2 A and B criteria. A is persistent deficits in social communication and social interaction across multiple contexts as manifested by following: currently or by history. One is deficits in social emotional reciprocity, ranging from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. There is also deficits in use of language and behaviors for social interaction, ranging from poorly integrated verbal and non-verbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures to a total lack of facial expressions and non-verbal communication. So this total lack of facial expressions and non-verbal communication is not seen as often. There's also deficits in developing, maintaining, and understanding relationships, ranging from difficulties adjusting behaviors to suit various social contexts, to difficulties in sharing imaginative play or in making friends, or to absence of interest in peers. So there is a wide variability which is diagnostic of autism. Second criteria is restricted repetitive patterns of behaviors, interests, or activities manifested by at least 2 of the following, currently or by history. One is stereotyped of repetitive motor movements, use of object or speech, like simple motor stereotypes, lining up toys or flipping objects, or echolalia or idiosyncratic faces. Second is insistence on sameness, inflexible adherence of routine or ritualized patterns of verbal and non-verbal behavior. So in stereotyped repetitive motor movements, most commonly seen thing is hand clapping or finger flicking. These 2 are most common behaviors. And in insistence of sameness, it is like using the same route for going to a place or following the same schedule at home. And if there's any change, they become very, very upset. Highly restricted fixed interest that are abnormal in intensity or focus. Like today, there was a child who was only interested in trains. He only had toys related to train. Whenever he would be upset, he would want to look at a toy train, and he's only 8 years, but he knows the schedules of trains and all the details of metros and everything about trains. Hypo or hyper reactivity to sensory inputs or unusual interest in sensory aspect of the environment. And I'll come to this again later. I'll explain this, what it is and what kind of behaviors it leads to. What needs to be specified is the severity, whether they require very substantial support, or support. It should be present in early developmental period. It should cause clinically significant impairment in social, occupational, or other important areas of current functioning. And these disorders are not better explained by intellectual disability or global developmental delay. Though intellectual disability is a very frequent comorbidity, and so is attention deficit hyperactivity disorder. We also need to specify if it is with or without intellectual impairment or language impairment, or any associated known medical or genetic condition like MECP2 gene, Fragile X, or intrauterine valproate exposure. This needs to be specified. Now coming to management, first becomes the assessment. Since it's a complex disorder, the assessment should as far as possible be done by a multidisciplinary team, which consists of psychiatrists, psychologists, pediatrician, special educator, occupational therapist, and audiologist. And beyond longitudinal changes in the ASD symptoms, the assessment of co-occurring physical and mental health conditions is essential to provide quality care. In an individualized setup, the psychiatrist can make good assessment and manage some therapies with specific referral, as in small towns. So it's not necessary that unless you don't have the whole team, you cannot do anything. So early intervention is important, and diagnosis of ASD and associated condition needs to be done. Early diagnosis of an intervention for autism are more likely to have major long-term positive effects on characteristics and later skills. Again, symptoms I have written and striked out because symptoms are related to a disease, while this is supposed to be a condition. And autistic people say that we are like this only. And they don't want to be, label their characteristics as symptoms. So early intervention may begin as early as 2 years of age or even earlier if it is diagnosed. And because of the plasticity of the brain, treatments have a better chance of being effective in the longer term. Early intervention not only gives children the best start possible, but also the best chance of developing to their full potential. What we also need to do is to rule out other conditions like hearing impairment. We need to evaluate for comorbid conditions like seizures and search for underlying etiology like a genetic syndrome. A medical history, physical examination, audiological evaluation, and other optional investigations such as EEG, brain imaging, metabolic testing as appropriate may be useful. Some features related to ASD require additional assessment, including presence of cognitive or language impairment, presence of developmental delays or co-occurring diagnosis such as ADHD. It may add complexity to the diagnostic assessment process. So given these complexities, cognitive and language assessments and consideration of comorbid emotional and behavioral disorders are recommended for all patients with ASD. So now here I have listed few cases which are from my clinical practice. So here this child, PR, who was, when he came, was 16 years, student of class 11. He had normal milestones. He does not interact with others at school, and there is occasional head banging. He started getting violent thoughts of murder or kidnapping girls, and he wanted to be like Hitler. He would do strange gestures to prevent bad events from happening. In obsessive compulsive symptoms, he had checking, washing excessively, and he also wanted things in pairs like magazines, scooter. He would insist that his mother should be around, and he would not go to meet relatives. So can someone share in the chat box that what diagnosis we should be considering and why? OCD. OCD because he very clearly has checking, washing, and strange gestures, and then violent thoughts and all this. But at the same time, he didn't have many friends also. His interaction with his peers, even his family members, was not up to the mark. And so initially he was diagnosed as obsessive compulsive disorder and he was treated on those lines also. But later it was revised to Asperger syndrome. And now this child has finished his Bachelor in Fine Arts from Arts College, Chandigarh. Now this is another case, 14-year-old boy from Jalandhar. He came to the clinic. He had normal milestones. He was refusing to go to school and he wanted to watch television whole day. He was not studying and he had no friends. There was no other problem behavior except that he doesn't want to go to school. So what diagnosis can we consider here? ODD, school refusal. Yes, these can be thought of, but then Asperger syndrome is also a possibility because again, he does not have any friends and he just wants to do this excessive preoccupation with one thing, that was television. Doesn't want to do anything age approved, just watching television whole day and do nothing else. This child didn't come again. He came only once. So this another child who was 3.5-year-old boy. He used to speak only 2 words. His motor milestones were normal. He was just spending excessive time on mobile. Hyperactivity was present, hence he was not attending the playgroup. Joint attention was there. Emotionality was normal and he was able to follow commands. So what are the possibilities? I've already typed it. It was language delay. And because of excessive time on mobile, parents were more concerned that does he have autism. So this was a 2-year-old child. He wouldn't play. He had delayed milestone. And he would respond to calling. He would cry when hungry. Eye contact was present and emotional attachment with parents was also there. What are the possibilities? Simply intellectual disability. So though there was no play, but then his emotional attachment with parents was normal. Yeah, global developmental delay is the right term. This was another case. GS 7-year-old male child was brought by parents with complaints of delayed onset of speech, difficulty in learning, inattention, difficulty in writing, less peer interaction. He cannot answer back to younger children. There was poor voice modulation and he would repeat words. There were sensory issues present, excessive jumping when excited. Vocal and facial tics were present and eye contact was less with teachers. In past, he had received a diagnosis of mild autism based on childhood autism rating scale. His mean IQ was 92. So what could be the possibility? He had already received a diagnosis of mild autism. So when we are making a diagnosis here, what are we looking at? SLD. SLD can be comorbid with other neurodevelopmental disorders like autism. His diagnosis was ADHD inattention. So this PN 6-year-old female child was brought by parents and she would not sit still. There were delayed milestones. Speech was 2-word sentences at 4 to 5 years. She would remain lost in self. She would laugh without reason. She was poor in academics. There was adamant behavior. On IQ testing, Gessel's drawing test score was 110. On BSMS, it was 68. On MISIC, verbal was 83. So there was a variability. What are the possibilities? Her ESA score was 89. She had borderline intelligence. Because her emotional behavior was with others was okay, her communication was all right. On GK, 8-year-old female child presented with not talking to anyone for 4 years. Doing well academically, but no friends in school. She would keep sitting silently in class. Does not look up to father when he comes to pick her up after school. Does not ask for food or water in school. She talks to parents at home, but becomes quiet in presence of other family members. She hides behind her mother in social gatherings. She laughs at funny situations in school and gives eraser, etc. when a child in class asks for it. IQ was 110. What is the possibility? Rett syndrome, selective mutism. On ESA, the score was 72, which indicates mild autism. But her diagnosis was selective mutism. I wanted to talk about this case because at times we just administer ESA and we make a diagnosis, but ESA is not for making a diagnosis. ESA is for assessing disability in a child with autism. So this AS 5-year-old male child brought to OPD as he was not speaking adequately. He was not able to understand much. He had poor eye contact, poor attention span. He had jaundice at the age of 3 years. He would ask for food, play adequately with other children, but his speech was unclear. His SQ was 52. On ESA score of 87, mild autism, but diagnosis was mild mental retardation rather than autism. So I have shared all these cases to understand that what kind of differential diagnosis we need to keep, because they were all symptoms were somewhat similar. So prevalence of ADHD symptoms in individuals with a primary clinical diagnosis has been reported to be 13% to 50% in general population. So whenever in doubt, the intervention can be started. This is what we do, and a diagnosis can be made later. Similarly, it is difficult to differentiate between intellectual disability and ASD at times, and the comorbidity is high, about 30% to 45%. So cognitive ability and intellect in autism needs to be assessed on a battery of tests, and it's just not just one test on which we can do that. So we also need to ask parents that why have they come. After detailed history, clinical examination, play observation, important to ask their reason for coming. If we go with our usual mindset that we have to suggest treatment or we have to do this, it doesn't work. They can be coming for reconfirmation of diagnosis. They may have already gone to many places. They may be coming for treatment. They may be coming only for certification and nothing else. Or maybe the school has asked for a report and they do not really want anything more than that. Or maybe they need to make important decisions about school, the place of stay, like the city, if they are in a transferable job and they want to find out about the therapies. Or maybe they are in town for a month, coming from Australia or UAE or anywhere, Canada, because there, I mean, they are aware that the child has problem, and over there, the time taken to enter into that therapy system is too long. And maybe they want a specific guidance. What I usually ask parents is to write their important concerns and how a usual day goes by, because it really helps them to clarify what are they worried about. Because otherwise, when you're talking to them, they are really worried about so many things. But when you ask them to write, they are better organized. So psychoeducation for the family becomes a very important component. And informing the diagnosis to parents when the child has ASD, because when we are doing that, we have to keep 2 points and we need to inform them that it is a neurodevelopmental disability. It is lifelong and it starts in utero. It is not that because father was misbehaving, because mother was not paying attention, because so and so thing was happening in the family, the child has developed autism. It is not so. And also many people come asking ki isko theek kar do. So what is it theek kar do? There's no theek kar do. We have to see that how we can best help the child. It is not produced by vaccines. That we can say that more clearly now. About there was a book that I read about 15 years back in which they had shared data from many states of United States and which was sort of pointing out that it is due to the vaccine. But now with the thimerosal out of the vaccines and still the prevalence rising, we are clear that it's not because of vaccines. And it is not caused by bad parenting or due to behavior of other family members. Because usually whenever the parents notice some behavior, they look at what Dadi was doing, what Nani was doing, what father was doing, what mother was doing. And also, all children may not be similar with or without autism. It is certainly true that early therapy helps. Education may not be the only aim, because what parents ask is, ye padh to lega. But then education is not everything. It's just one part. And also they need to talk to others about autism spectrum disorder openly. Because when they start talking, they find a lot of support and they are able to share their experiences. Many parents feel so stigmatized by their child's behavior that they don't want to talk. They don't go anywhere out, and their own lives are so troubled that in that state of mind, they cannot help the child at all in any way. They need to talk to other parents of children with autism spectrum disorder. We have to tell them that the path ahead may be difficult, but they need to reach out for help at every step of the way. We also need to furnish examples of individuals with autism spectrum disorder, which we have plenty of people who are successful. We also need to assess parental stress and we need to address it. It's not only the child, but the whole family that we need to take into consideration. We need to assess their resources in terms of time, the place, and the caregivers. Because many a times they're coming from a city which is a little far away and they cannot come. Or maybe they're coming from a city which is far away, but they're willing to come every week. So whatever it is, we need to look at that. And so now coming to the non-pharmacological treatments, these form the mainstay of approaches towards autism. The therapies which have a definitive role include behavior therapy, occupational therapy, speech language therapy, applied behavior analysis, social skill training, physical therapy, cognitive behavior therapy, and play therapy. So all these have definite role. So in structured educational and behavioral interventions, we have a few therapies like early stage Denver model, applied behavior analysis, and secrets, which is social communication and emotional regulation and transactional support. All these are very delivered in a very structured way. In developmental interventions, we have therapies which focus on building emotional relationships, fostering social communication, and building social skills. Most commonly practiced are flow time, individual differences, relationship-based, and relationship development interventions. For communication, because most of the parents, they ask कि ये बोलने लगेगा? I mean, will the child ever be able to speak normally? But then that is not what is required. What is required is the child is able to communicate the needs, emotions, and everything else. So they can be taught sign language. There may be a communication board. Visual support can be there. Picture exchange communication system can be used. And also use of social stories and social skills training can be done. In educational assistance, structural educational approach with explicit teaching and formulation of individualized education plan is important for every child with autism. TEACH is treatment and education of autistic and related communication handicapped children. The goal of structured teaching is to promote meaningful engagement in activities, flexibility, independence, and self-efficacy, not mastering the curriculum. Many schools ask for a shadow teacher, and that helps. Initially, that helps to a certain extent. Now, coming to sensory integration, the aim of sensory integration therapy is to improve the ability of the brain to process sensory information so the child will function more adaptively in his or her daily activities. The others are CBT for anxiety and anger management in high functioning youth with autism spectrum disorder. Animal assisted therapy, particularly use of trained dogs, has been gaining increasing popularity, not in India though. In complementary and alternative treatments, they have not been found to be mainstay. Examples are special diets, GFCF, herbal supplements, chiropractic care, arts therapy, mindfulness, and relaxation therapies. In special diet, there was like camel milk or stuff like that. Those are also quite popular. ABC approach is basically for altering the behavior, and behavior is controlled through changing antecedents, enriching the environment, limiting the environment, simplifying, structuring, and addressing the child's need. By changing the consequences, it is like operant conditioning, differential reinforcement, and changes to the reinforcement schedule like extinction, timeout, response cost, or overcorrection. So what behavior do we want to change? In deficits, there is language, play, social skills, and executive functions. And for this, we need skill repertoire instructions. There are behavior excesses like self-stimulatory behavior, maladaptive behavior, in which there's tantrum, aggression, and non-compliance. And for this, behavior management is used. Now coming to sensory integration deficits and behavior issues. In sensory, we all know about the 5 senses, and besides this, there is vestibular and proprioceptive. So when there is hyper or hypo-responsiveness to touch or the tactile sensory, then in hypersensitive children do not allow themselves to be touched. They wear only soft clothes, like only soft t-shirt. They wear socks all the time, and they do toe walking because they do not want the sole of their feet to touch the floor. They have to wipe their faces many times while eating. If any food particle touching on their face, they have to first clean it. If there is hyper-responsiveness, then they seek out a lot of sensations. So they keep rubbing various surfaces. And they like a lot of hugging. And they do not like to wear chappals and socks. In auditory hyper or hyperresponsiveness, if it is hypersensitivity, then they keep their ears closed and they try on hearing loud sounds like pressure cooker whistle or grinder or lawnmower, and most difficult to take them to a wedding where there is loud DJ playing. And if there is hyposensitivity, then they want to stimulate their auditory sensation all the time. So they keep making some sound. They keep tapping they keep humming, they keep making some sound. When there's visual hyposensitivity, they like to look at flickering lights. They like to look at fan. They switch on and off fan and they look at it. They like to look at running water, opening the tap and looking at the water running. And they poke their own eyes like with fingers. And most common is finger flicking. If it is hypersensitivity to visual stimuli, they shield their both sides of the eyes. In tactile issue, the issues are like they avoid getting messy in glue, sand, and finger paint, etc. They don't want to do that. They're sensitive to certain fabrics, and they don't. The climbing and bedding also. They touch people and objects at irritating level. They avoid going barefoot, especially in grass or sand. And there's also decreased awareness of pain or temperature. So what can be done to address that is finger painting or using the Play-Doh or putty or clay to make different kind of things. And walking in the grass with no shoes or swimming or drying off with towel, rubbing the skin with the dry towel. Then texture adventure bins can be there and clue projects can be there. Or on a fabric, different kind of smaller textured things can be pasted and the child can rub on it so that he feels those sensations. In vestibular and proprioceptive movement and body position, he becomes anxious or distressed when his feet leave the ground. So he doesn't want to jump and all. Or they may be avoiding climbing or jumping. So that is what it is. They avoid playgrounds equipments or seek all kind of movement which interferes with daily life. They take excessive risk while playing, walking on the parapet, and continually seek out all kinds of movement activities. Like most common is rocking in the chair. They are hung on other people, furniture, objects, even in familiar situations. Activities which can be done for this is any play with leg movement and head, shoulder, knees, and toes, dancing, sitting and spinning, rolling, or rocking chair. Proprioceptive activities are stair climbing or sliding, playing tug of war, pulling or pushing, and hitting a punching bag. The calming techniques here are helping with heavy work, joint compression, lavender, vanilla, or banana scents, and reducing the noise and light level, and sucking through a straw. Now, sensory diet, it means finding the best combination and timing of various sensory inputs to cope with sensory integration dysfunction. It is a plan that includes an ordered progression of sensory and sensory motor activities, including a combination of alerting, organizing, and calming techniques that fulfill physical and emotional needs. It helps in improving attention span, attaining the sitting for learning, and reducing the repetitive activities and meltdowns. So many of the behavioral problems or the behavior characteristics that children with autism have are due to their sensory issues. So when these sensory issues are addressed, they are much calmer. So that is what helps them. Now coming to the pharmacological treatment of symptoms. So repetitive stereotype behavior, for this, there's no US FDA approved drug. SSRIs may help, or haloperidol, risperidone, and aripiprazole can be given. For hyperactivity and inattention, methylphenidate can be given. but again, no US FDA approved drug. Clonidine and imipramine can also be tried. For irritability, aggression, and severe tantrums, atypical antipsychotics are US FDA approved. For core social impairments, there's no drug treatment approved. For unusual sleep pattern, melatonin can be given, but more effective than melatonin is physical activity and a structured routine in which going to bed at regular time is done on a daily basis. And with melatonin also, improvement in restricted repetitive and stereotype pattern of behavior, activities, and interests was seen. And behavioral disorder and affect dysregulation. Now there's a lot of research going on omega-3 fatty acids, that this may improve hyperactivity, lethargy, and stereotyping. However, there was no improvement on GAF and social responsiveness, and effect size was small. For vitamin D, there were 2 open label trials. There was efficacy in prevention and some improvement was seen. In gut microbiota probiotics, again, small studies. Then microbiota transfer therapy that combined antibiotics, a bowel cleanse, a stomach acid suppressant, and fecal microbiota transplant study. This was a small study done only on 18 children who had GI symptoms. So under research therapies are like IV suramin, vasopressin receptor analogs, vasopressin receptor antagonists, intranasal oxytocin, and TMS. Both ICMR and Indian Psychiatric Society condone the use of stem cell therapy in autism based on the review of available scientific literature. Though this was going on for quite some time and there were some centers who were doing it quite excessively. So now coming to the newer issues like screen time. So during pandemic, the screen time had increased for everyone, and also for young children. So this increase in screen time is associated with melanopsin expressing neurons and decreasing GABA neurotransmitter, and thus results in aberrant behavior, and it decreased cognitive and language development was also seen. So virtual autism was also seen, which was that exposure to screen time under age 2 years can give rise to symptoms like autism. Then case reports suggest complete reversal, so case reports, mind you, of ASD symptoms, and normal development after screen time was curtailed. So in our clinic, what we have seen that the number of children coming with autism spectrum disorder had increased a lot after pandemic, and most of the children were about 3.5 years. So that is, they were either born during pandemic or they were about 6 months to a year when pandemic started. And in many, it was not a virtual autism, it was a real autism. And this was the number have really increased. So WHO infant guidelines says that no screen exposure till 1 year of age. And it's important to keep this in mind, that no screen exposure. So autistic people may be drawn to screens because they provide a repetitive and predictable interface that is easily customized to the specific interests of an individual. They can choose the content that they want to see. Digital media provides the user with visual and auditory engagement that stimulates neural pathways. For many autistic children and adolescents, these neural pathways are not always stimulated during face-to-face interactions. A large study from USA found no difference in screen time between children with and without ASD. In both, it was very high. The benefits of screen is that it creates learning opportunities. It increases knowledge. It increases opportunities for social contact and support. But the risks are negative effects on sleep, problem with attention and learning, higher incidence of obesity and depression, exposure to inaccurate, inappropriate, and unsafe content and people, and compromised privacy and confidentiality. Now coming to national policy updates. The enactment of National Trust for the Welfare of Persons with Autism, Cerebral Palsy, Multiple Mental Retardation, and Multiple Disabilities Act was done in 1999. And the trust promotes measures for the care and protection of persons with disability by appointment of guardians and trustees. It facilitates realization of equal opportunities, protection of rights, and full participation of these individuals. The Right to Education Act 2009 and Sarv Shiksha Abhiyan are the Government of India's flagship programs for achievement of universalization of education. They have a mandate for inclusive education for all children with disabilities, including autism and intellectual disability. Another important development has been recognition of child and adolescent psychiatry as an academic discipline. The National Medical Council or Medical Council of India has made it mandatory for all departments and institutes imparting PG training in psychiatry to have child and adolescent psychiatry services. In 2010 and 11, ICMR announced plans to conduct in-depth research in autism spectrum disorder. Since then, several projects addressing early diagnosis and prevalence, evolution of diagnostic threshold criteria for Indian population, standardization of multidisciplinary assessment, functional imaging studies, correlation studies with neuropsychiatric morbidities, standardization of therapeutics, genetic studies, biochemical markers, intervention studies, and services for care, development of training modules for parent and children, development of modules of care at school and home, special education and remediation, and speech therapy and sensory integration studies have either been launched or are in pipeline. So there's a lot of work being done on autism spectrum disorder. So with this, I conclude. Thank you so much.
So request you all to post your questions in chat.
Just to begin the conversation, Dr. Preeti,
Yes, sir.
1980s or say early 90s, diagnosis of autism was very rare even in the child psychiatric clinics. Now the criteria for diagnosis, they have also been broadened by including, especially in the DSM-5, by including number of conditions together and making coming under the autism spectrum disorder. That's one thing. Other thing is the last 40 years, lot of changes have occurred in the society. Families have become smaller and smaller. Our urban population has increased by nearly 10% in the last 40 years. Outdoor activities have come down. People are more strung to screens. Children are, families have become smaller. Social stimulation has come down. So has there been a genuine increase in the autism spectrum disorder, or it's a broadening of criteria, or it's a social change that is also responsible for? Because when I was a resident, prevalence was considered, I think, 3 per 10,000. At that time, the disintegrative, what's that? There are 3 or 4 conditions.
Disintegrative disorder. Yeah.
Yeah.
Childhood disintegrative disorder.
Childhood disintegrative disorder. I still remember I made this diagnosis in one of the workups with Dr. V.K. Verma. I still remember, and I don't remember, and remember seeing only one patient of autism during my 4 years in psychiatry at PGI. And so that was the situation with the. So what's your take on this actually? Is there increasing prevalence or broadening of criteria or social change? Or it's only biology?
Sir, thank you so much, sir, for this question, because this I started running child guidance clinic in 1998. So since then, I'm running 25 years. I'm running child guidance clinic, and I still remember the first case of autism spectrum disorder which I saw, and I wondered that how many. I mean, I had seen childhood disintegrative disorder during my training, but autism I've not seen. And then I wondered that is it really increasing? But then if I recollect, now the numbers are too many. And also if we look at the graph from USA that I was showing, it's absolutely steep rise in the numbers. In India also, the numbers are increasing. That is what I would say if I look at the clinic. In community samples, there are, I mean, it cannot only be because of the social change, because there's definitely something more than just a social change. And as far as the social environment is considered, if it is mild case of autism, then because of the environment, it may get missed. If it is the child from the rural area and I mean, he's happy going to the farm and being with the cows and all that, then it's not a problem. He can very well be there, and nobody will think that there's something amiss there. But in cities, in urban area, and schools, it does look like a problem. Currently, I mean, the bigger debate is that is it really that there's a difference in Western countries versus Asia, barring Taiwan and Japan. So what is currently the thinking about it is that the screening is not being done universally in India. And it is also that the diagnostic criteria or people who diagnose, because about 17, 18 years back, there were children who would come after going to many institutes and they were being seen by pediatricians, psychiatrists, but no one would say the word autism. No one would give them that diagnosis. They would say, there is some problem. This problem is there, that problem is there, but then people were not willing to label it. So, but important thing is that unless we identify something, we cannot give any intervention. So, like in the beginning, I also said that if we are not able to differentiate, at least we should start the intervention. The diagnosis can be done later. Because there were many cases in which I've spent over 6 sessions just assessing the child to make sure whether he has autism spectrum disorder or only ADHD. And in many cases, we do that. We call again, because on few days, child may be cranky. For some other reason, his behavior is different. And at times, according to the father's report, you can diagnose the ASD immediately and mother says something completely different. So that also we have to keep in mind. So that is why it is not something that we sit in OPD and make a diagnosis immediately. We have to look at everything and make up our mind clearly and then say. So in chat box, there is one question that how do we assess joint attention and how we, how do we explain? So the joint attention is when we are, when I point to something and the other person also looks in the same direction. That is joint attention. So a child, when shown a bird, a moon, aeroplane, a cow, a dog by mother, then if that child is able to look at that, then and then looking back at the mother, because if we just consider a scenario where we are in a crowded place and we want to just communicate something to our friend, we look at the friend's eyes and then we look at the another person whom we want to point out, and then we say that whether that person is seen or not, then that is the joint attention, that that person is seeing what we are seeing, and then we have confirmed that this person is also seeing the same thing. So that is joint attention. Also, the child bringing something to show to the mother. Maybe it is, it can be anything. It can be an insect. It could be a drawing that he made, or he found something interesting which the child is finding of interest. And he's showing it to the mother. That is joint attention. That, see, I found it interesting. You also look at this. That is joint attention. So for examining it clinically, we have to do this in the playroom during play observation. So otherwise, or we are spending sufficient time with the child in the OPD so that we can do that. But play observation is one thing. So then this question here, that how to differentiate between virtual autism and autism. So virtual is something which is having symptoms like autism, but it is not truly autism. So in this case, the child was born in 2020 March, and or maybe January 2020, and when the lockdown happened, the father and mother both were working from home and there was no one else. They couldn't go anywhere. No one could come to their place. And for babysitting, they were using the screen. So they were giving their mobile phones or iPad to the child, and they were happy the child is not disturbing. And so when this continued for 1.5, 2 years, and child was still, because during pandemic, children were not even taken to the park to meet other relatives. So this was a big problem. So, but when the opportunities are given, then the child is able to overcome that. And then his social interaction and communication and other behavior are coming back to normal. Then we say it is virtual autism. If it is not coming back to normal, then we would say that it is something else. So then this question from Mr. Pankaj Mahal, that which scale can be used to screen ASD in adults, as most of the scales are valid till 18 years only. So not even 18 years. In fact, the Ministry of Social Justice and Empowerment asks diagnosis to be made based on inclination, which is applicable only till 9 years of age. So it's not even 18 years. So it's basically clinical history based on which we make a diagnosis. And it is not unusual to diagnose autism spectrum disorder even at 18, 19 years, because when the person has some other kind of problem and then they come to your OPD and they are discussing their problems, and again, it's not in one sitting that you will be able to make it. You will have to spend considerable time finding about details of many other things. Then you can diagnose. And there is one Australian scale for Asperger syndrome, which I find good for Asperger in adults. That is for adults.
I think one of the important reasons why diagnosis is likely to be missed is not spending enough time. And it's not a diagnosis which one would be able to make on the first consultation. It requires longer observations and definitely some investigations, also sometimes psychological assessments and sensitization to the diagnosis, because we are not trained. We don't have most of us don't have enough experience in making the diagnosis, and we are not seen many and the children also don't reach the clinician. That's also only, it's only when the child psychiatry services are there, the child would be brought by the parents, and parents would also feel that child is not socializing. So that awareness is lacking. I think the National Trust Act, I think, was one very important initiative which brought focus on autism, because the word autism was used in the act itself. So that has
Yes, sir.
brought sensitization also amongst the psychiatrists.
So in fact, there are many cases in which children, the parents didn't think that it could be autism also. Like there was this child who was going to a regular school, and the only problem behavior that was that he would sometimes shout inappropriately in the assembly. So, and then other things were that they were from a Sikh family, and in the language with grandparents and all was Punjabi, but the child would speak only English and no other language. And his poor eye contact and other things were not paid attention to by anyone. And every time, only focus was on his academic performance, which was more or less all right. So, till his behavioral problem started, he was never assessed, which was age 10 years. So, is this question that in case 2, diagnosis of Asperger was made. Excessive preoccupation with television was considered to make a diagnosis. Yes, you are very right. And that is why he has nothing else. It wasn't preoccupation. It was a solitary activity of watching television and sleeping and nothing else. The children who are watching television excessively, they are watching, like, say, these days it's anime series which they are watching, or earlier there was something else, and for younger children the other cartoon series. But as a solitary activity, excessive preoccupation is different thing, but as a solitary activity is different thing. But in this child also, why I brought this case here was for the same reason, that TV viewing was a solitary activity, nothing else. Not going out, not going to any party, not meeting anyone when someone comes home, refusing to go to school. Children who are watching, who have excessive preoccupation with television, are also going to school. They are watching television after coming from school. They are not going to playground. They are watching television. They are missing few family functions, but they are going to the few where they enjoy. But this child was only watching television. So that is why, and also I mentioned that I've seen him only once, but I thought this is important to keep in mind when we're looking at how to make a differential diagnosis in the various scenarios which can present to us.
There is one more question by Dr. Sivangi. Why do some children with the more screen time are prone for visual autism and not others?
Yeah, so I would say that virtual autism, one would label after the child has become normal. I mean, after his social and communication behavior is normal and there's no other restricted repetitive behavior. And why someone is more prone? Maybe because he has other predisposing factors, and maybe it was never a virtual autism. Maybe it was autism only and lower on the less severity. That could also be one scenario.
Any other questions from the audience? You can raise your hand or type in the chat.
What percentage of patients, children with the ADD from the constitute the number of patients children who are coming from disability? Is it about the same as mental retardation or intellectual disability, or they are lesser?
So it's certainly lesser than the intellectual disability, because intellectual, and I think also because many people are not aware of the disability and that they should get disability certification done. That also is, and also in many centers, the awareness about giving a disability certificate is not there. Like today, I was seeing a case. The child is coming to me for last 12, 13 years. His IQ is in average range and he has autism spectrum disorder. He is from Patiala, so we have done an assessment and given him ESA score that go and get the certificate done from your state. He comes with the mother comes that they are asking for IQ. I said, but we have already written that his IQ is in average range. What I felt that over there, the doctors are not aware that for autism, IQ can be normal also. So they're asking for IQ again. Or maybe they just want to buy some time and so they have asked for it. So disability, I mean, also, sir, the disability needs to be given at age 6 years as per the guidelines of MSGOE. But if some benefits are to be given, those are for early intervention. So we cannot wait till 6 years of age. So that is again a tricky thing. And in my OPD, I do give a disability.
And what percentage of children? What percentage of children with ADD would
ASD?
What percentage of ASD children would have more than 40% disability?
Sir, I feel that mostly when we have diagnosed, they are coming into more than 40%.
They are coming the benchmark.
Yes. Yes. Because on ESA, they are definitely scoring 70 and above.
Yep. So, Preeti, if there are no more questions, I think we can wind up.
Thanks, sir. Ma'am, any other assessment? I mean, you had done it interactively during the session itself. Would you want to ask the participants for any other assessment?
Yeah.
Any other assessments? I mean, like, I want to assess them. I've not planned for that, so I can't really say that. I kept those case minutes to keep it interactive and also to give them some food for thought about differential diagnosis.
We can have comments from Dr. Sood. Dr. Sood is a public health expert.
Sir, I will just mention that this was a very good interactive session. Being a non-clinical specialty, I was also able to understand many of the things which Madam has explained. So on behalf of the National Academy of Medical Sciences, I would like to thank both the experts for making this evening session so interactive and useful for our participants. Special thanks to Dr. Preeti Arun for making this complex issue so simple, and especially by adding the cases, we have made it more interactive. I'm sure that the resident and the students, MD students, they have learned a lot from this session. Thank you so much, and we look forward for your support in future also. Special thanks to Professor Chadha for making this possible by identifying the best speaker as well as the best topics. So we are grateful to you for your support, and we look forward that the next sessions, which are going to be covered in the month of June, they are going to be equally, I think, interesting for our students. Thank you very much. I will also like to thank the students who have attended this session for raising some of the important questions, and I hope that this will be useful for them, not only for their clinical practice, but also from the examination point of view. For the information of the student, I would like to mention that from next month, in the month of June, we are going to cover 3 themes in parallel. For example, the 4 sessions which are left over from the psychiatry theme, we are going to cover on 10th, 17th, 22nd, and 29th of June. In addition, we are going to cover another theme on hematology, where another very good expert will be taking session on 1st, 3rd, and 6th of June. And there is one theme on diabetes. Dr. V. Mohan, who is a very eminent personality in the area of diabetes from Chennai, is going to take session on diabetes on 20th and 27th of June. So please make this information available to your friends and colleagues. We have already sent you the e-brochure as well as the detailed link, so you can always join. And the next session, which is the last session for the month of May, is on 30th of May, where we are going to cover the 6th and the last session of the series on hepatic disorders. So that again is going to be a very interesting session on autoimmune liver diseases. So we hope to see you and in large number. In case you have any question, you can always send us in advance, and we will request our speakers to include those questions when they are presenting the lectures. I will also like to thank Dr. Preeti for helping us in organizing this session. So thank you so much for your support. And again, from IT side, Mr. Ravi and Mr. Anil has helped us in organizing this session. So once again, I will like to thank all for making this session so interesting and interactive. Thank you very much and good night.
Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Preeti.
Thank you, sir.
So I declare today's academic session closed.